Thank you. It's a pleasure to be here, and I'm very honored to talk to you today. Great talk from Dr. Johannesson. So I want to just follow up, and part of my talk today was, I know some of you are considering maybe a future career in veterinary medicine or in science, and I wanted to talk to you about how sometimes your road to your goal takes some turns and twists, but I think you should just always keep your mind open and continue down the journey. So I'm going to share a few more than 2 slides about my journey, but I'll talk a little bit about the science I was involved in along the way. So, like many of you, I had a lot of thoughts in undergrad whether I wanted to pursue a career in veterinary medicine. I grew up in a rural environment, but I also had a lot of interest in science. And so I thought, is there a possibility that I would ever be able to have best of both worlds? So my undergraduate education was at Gettysburg College, and I obtained a bachelor's in biology. And part of the turning point in my academic, I guess, or my career path was when I got to participate in a summer research project at the University of Pennsylvania. So they have a School of Veterinary Medicine that's located in Philadelphia as their main campus. However, they also have a campus where their large animal hospital is outside of Philadelphia in the New Bolton Center. My mentor was Dr. Virginia Reef, and my summer research project was actually focused on unfortunate problem that happened in that area that summer. There was an outbreak of Monensin toxicosis among some horses. So let me just back up for a second and talk about Monensin. Monensin is a common feed additive. It's an antibiotic that can be put into cattle feed or other ruminant feed. And it's got an important health benefit in ruminants to prevent certain parasite infections. However, Monensin is highly toxic to horses, and it's especially cardiotoxic. So this large feed company in the Northeast had a problem in their factory. They were manufacturing cattle feed with Monensin, and there was a lever malfunction, and unfortunately the next batch of feed was equine feed, and so it was contaminated with Monensin. So there was an outbreak of Monensin toxicosis among horses. So fortunately, I was very honored to be able to participate with Dr. Reef. She's a renowned equine internal medicine specialist, and especially focusing on cardiology. So as part of her research team, we went out to these farms and did physical examinations on the affected horses. We did EKGs, and we did echocardiograms. So, sorry, this is the whole reason why I was so enthralled. Just to show you, real time, we can look at horses' hearts with ultrasound. And this really sparked my interest. I'm like, oh my goodness, how amazing is that? So we also did some blood biochemistry on these horses. We got a lot of useful information that helped us to understand Monensin toxicosis and how horses can survive versus and not survive, and what are the effects. And because of it, a lot of feed companies have placed special safeguards in their manufacturing. They may even manufacture ruminant feeds at a separate facility so that actual accidental contamination with Monensin may not occur. So there's been lots of improvements in the industry related to, unfortunately. So I graduated from college and then decided, well, I'm not quite ready, I think, for vet in school, but I'd like to, this really sparked my interest in science. So I obtained my first job out of vet school was as a research technician at the National Cancer Institute, and they had a Fort Detrick campus in Frederick, Maryland. And the National Cancer Institute there was federally funded and did biomedical research. The division that I worked in at the time was related to cancer treatment, development, and therapeutic program. They looked at therapies and strategies for helping find new cancer treatments, but there also was a division of it that decided, well, we're examining the potential drugs for cancer. But also, an important disease at the time was HIV, and HIV was still a little bit more in its infancy. This was in the early 90s. So I worked in a large-scale anti-HIV drug screening lab, and this lab evaluated a lot of synthetic and semi-synthetic or natural products. So interesting stories. The researchers would follow the shaman in the rainforest of the Amazon and collect plants and species, and they had an extraction lab next door. So many of the anti-HIV activity drugs that we have today came from these preclinical drug discovery programs similar to ours. And just to talk to you about the volume of drugs we examined, we looked at over 40,000 to 60,000 samples per year. And so many of the really important drugs today came from this. So a little bit about how that was done. All these were done in vitro, obviously, but we worked with a highly virulent strain of HIV. So a new grad, just out of college, and one of the most important lessons you learn is very good lab techniques and be very type A, very particular in how you do things. So in the cell-based system, we use a CD4 cell line, which is the target for HIV virus. So HIV was added to the cell line, and then we applied dilutions of the synthetic or natural extracts. And then from there, we incubated it and came back 24, 48 hours later and evaluated these compounds for two things. One is the antiviral activity, and this picture here shows how an infected cell would tend to form these very large, giant multinucleated cells or syncytia. So we look for syncytia, which is an indication that this drug did not work, it failed. And we also, the drug may have worked very well as preventing HIV infection in that cell line, but if it was toxic, if there were too much toxicity, that drug was rejected. So very interesting, and I think it's just a stepping point into my next pathway in my career. So from there, I got married and met my husband. We moved to Nashville, Tennessee, and I took a position as a medical technologist at the Veterans Affairs Medical Center in Nashville, and they worked in collaboration with Vanderbilt University. So unfortunately, I didn't have some drug screening lab to do, but I got involved in HIV research again by looking at HIV samples from infected veteran patients. And we used the flow cytometer to examine these samples. So in people, as some of you know, HIV causes depletion of CD4 positive T cells. So learning how to do flow cytometry, we did some research related to studying these patients over time, and then worked with researchers at Vanderbilt to expand some of the knowledge we obtained from these from the samples we obtained from the veterans. So a little bit about flow cytometry. A sample is taken, whether it's a blood sample or even a tissue biopsy or even cell culture samples, and they can be placed in conjunction with monoclonal antibodies containing a fluorescent marker or tag that are specific for cell surface markers. That sample is then run through the flow cytometry instrument, in which they're placed under high pressure through laminar flow into a single file and then passed through a series of lasers. And lasers can detect the size of the cells based on how much laser passes around the cell. Also, they look at scatter, how granular the cells are, different populations. We can also detect those fluorescent antibodies based on different types of lasers that are applied to those cells. And when you find a particular cell of interest, the machine can even apply electric current and sort that cell so you can collect a particular cell and then study it further. So I worked with Vanderbilt on a project on looking at a certain population of people with a tissue type and examining their T cells within that group. So it was very interesting. Again, it's another just benchtop research application that allowed me to, further expand my understanding of science. And there, we moved to St. Louis, and I got involved in industry at that point. So very different experience from where I'm coming from, from an NIH facility to then working in a hospital, then to launch to industry. So I learned very important techniques regarding monoclonal antibody development. Molecular biology products were developed, and so I would say that industry was very eye-opening and a great experience, and helped me to understand all the background from all the products I had used up to that point. But in about 1997, we took a new direction. I refueled my desire to go to vet school, and so my husband's from Louisiana. We moved back to Louisiana, and I entered into the vet. Was accepted, entered the vet school. It's a 4-year program, I'm sure many of you know. And after you graduate from vet school, you have very many opportunities. And I know many people just enter into practice. However, there's similar to human medicine, we have many specialties that have emerged in veterinary medicine. And this was going way back to Dr. Reef at the University of Pennsylvania. I reignited my desire to study internal medicine and become specialized in it. So I was accepted to a residency program, and an internal medicine residency program is a 3-year program. In addition to everything you studied in vet school, you go and study intensive training in physiology, diagnosis, and treatment of internal disorders. And at the end of the program, you obtain board certification, passing boards, etc. This program was combined with a master's, and so just a little bit about internal medicine and what we do as equine internal medicine specialists. So we look at various aspects, anything internal, so cardiac disease, going back to Dr. Reef, and that was one of the major interests I had initially. But also horses with neurologic disease. You'll see this horse in the upper right corner has encephalitis. So this horse actually has a protection on its head. It's head pressing and is not have a complete balance. It's atactic. We study critical care and help patients that have intensive needs. We also study muscle diseases, respiratory diseases, gastrointestinal diseases. So there's quite a wide range of knowledge that you need to know as an internal medicine specialist. And I think the biggest thing specialty training teaches you is how to think critically. And that can sometimes help you transfer that and translate it into science and into the laboratory. Just a few pictures to show you some of what we do. There's a horse in the upper left corner is in a sling, and so when a horse 1,000 pounds or more can't stand, we have to try to assist them to stand. And this is the large animal sling. We actually went to a racetrack and set it up and tried to assist this horse, had a muscle disorder. The middle right picture shows how we can do quite a lot of imaging in equine medicine. Many of the modalities that we have in human medicine, ultrasound, MRI, CT scan are available in horses as well. Just pictures of muscle biopsies and then endoscopy. We learn quite a lot about, we certainly don't do all areas of endoscopy similar to human medicine, but we this picture in the upper middle right shows an endoscopy picture of the horse's stomach. And here you see, so an endoscope, and a horse has to be very long, so approximately 3 meters in length to reach the equine stomach. So just a picture here, just to talk about internal medicine is not always confined just to organs, and we deal with horses that have muscle disorders. And this is a horse at the racetrack that had muscle atrophy. So equine internal medicine encompasses as well about neonatal care. And I stress to my students that in veterinary medicine, neonates are not just little horses. They're actually physiologically very different than adult horses. And so studying them and learning about the differences physiologically between newborn animals and then as they progress in age, their physiology is quite different and they require quite different care. Just to show you some of the fun pictures. This is I'll start with this foal. This was a miniature foal that we took care of for during my residency, and you'll see that there are quite a lot of tubes coming out of this foal. So we certainly have to care for these foals from their nutrition, to their hydration, to their oxygenation, and then keep track of all of those. Foals that are recumbent and unable to stand need to be fed. You see feeding through an intubated foal, feeding through a nasogastric tube. In special instances, of course, restraining foals can be very, very challenging, and so we're skilled in how to handle foals, take care of foals, and even take care of their mothers, because we can't forget about the mare is just as important part of the equation in the health of that foal. So how do we get from internal medicine into veterinary clinical research? Well, veterinary clinical research is certainly, as Dr. Johansson has talked about, is specific scientific research which we're trying to identify a clinical question. And in these going through as a veterinarian, we ask a lot of questions regarding the diseases that we treat. How can we better treat these animals, diagnose their problems, and prevent these diseases to begin with? Improving our diagnostics. Some of the tests that we've used for many years have become outdated, and we need to find new ways of detecting the disease. Improving our therapies, whether we're dealing with novel drugs or better methods to evaluate our current therapies. Sometimes the current therapy just needs to be reevaluated and reapplied in a different manner. Then at the vet school, we've participated in some large-scale FDA approval studies into new medications that help with horses in treating disease. Studying their safety and their efficacy is very important. And if all possible, we want to prevent disease in many cases. So the studies that we can design to help identify areas where we can prevent disease are very important. And then epidemiology, veterinarians are trained in epidemiology, and so we can have some insight into how disease presents in the population. However, clinical research does, Dr. Johansson said, how to recruit people for your Pennington studies. Well, how do you recruit animals for your clinical research studies? So at the vet school, we rely on recruitment of client-owned animals in many cases. We do also have a population of research animals that we can use that could potentially apply to a patient with spontaneous disease in certain instances. However, Dr. Baker, I know, has talked to you about Dr. Baker has talked to you about the regulations regarding animal use, and so we have to very strictly follow our IACUC, receive IACUC approval, strictly follow scientific standards, especially humane methods and animal welfare. We're always considering whether pain, if we're inflicting pain, is that necessary, and always avoiding pain in our situation, in our studies when we're designing them. Also, minimizing the amount of animals that you use so that you still can obtain scientific and statistical significance is important. However, yet you want to have enough animals that your study will show the difference if noted. So for instance, if you have a study with 3 animals, it may not be an accurate reflection of what's really going on in that particular disease state. However, you may not need 300 animals to show a significance. So we get into calculating our sample size, and that's a really important part of getting IACUC's regulatory role. And then ultimately, we also have to always consider non-animal methods. So if there's an instance or a case where a non-animal model exists that could replace and answer the question we want, we always should consider that first. interestingly, too, though, animal models can sometimes give us insight into human disease, and so there is some translational value, and translational studies can be very helpful. For one instance is, this is a foal. I'm going to show you a video of a foal. This foal has respiratory distress, and the disease is infected with a bacteria called Rhodococcus equi. You see an image on the left of what an infected lung would look like. These foals develop this disease between 1 to 3 months of age, or sometimes even a little older or younger, but the peak times are between 1 and 3 months of age, and they'll develop these large pulmonary abscesses. And the problem with this disease, it's difficult to detect until it's very severe. So we try to find ways to identify it early. Well, Rhodococcus equi has actually become an important pathogen in immunosuppressed people. So AIDS patients, people that are on immunosuppressive drugs, can succumb or can obtain Rhodococcus equi infection, and it can be very severe. So we have an instance where an important pathogen in people is also an important pathogen in veterinary medicine. So from beyond my residency, I began to work at LSU, and had the opportunity to work in equine field service. And so as a field veterinarian, I'm able to study, in addition to benchtop research, I can study things, outbreak situations or infectious disease as they occur in the environment, where the animals live. So some of the infectious diseases that I've looked at, Salmonella, and that's the main one I'm going to just talk to you about quickly at the end. And then I've looked at another pathogen, Lawsonia intracellularis, which is a pig pathogen, which has been noted as an emerging pathogen in horses in recent years. I've studied Rhodococcus equi, and then recently, as part of the summer project, we've been studying pituitary pars intermedia dysfunction. Just a few pictures about field medicine. So Dr. Johansson reminded me of how it makes me feel good that all this vigorous and strenuous work that we do in field medicine maybe hopefully will pay off with longer lifespan. But we're fortunate to get to see, and bring our doctors to their patients. And so many times our patients can't come in as well. So the final, briefly, I'll just kind of go over the one important infectious disease study that we did in recent years regarding Salmonella in horses. I'll talk a little bit about why we studied Salmonella in a minute, but we were curious about the shedding of Salmonella in thoroughbred racehorses in Louisiana. And so we designed a project to help identify and determine what the importance is of this pathogen in our resident horse population. Salmonella, as many of you know, is a very important infectious cause of colitis or diarrhea in horses. In fact, it's probably the most common infectious cause of diarrhea. And being zoonotic, there is a concern with transmission to people. And the CDC reports, and I don't have recent years, but back in 2005, they confirmed about 40,000 human cases. However, this is highly underestimates the total number of Salmonella cases that they actually see. Many people are not willing to submit a fecal sample right to your doctor to get cultured for Salmonella. So real estimates are probably more like 800,000 to 4 million cases a year. But going back to horses, and when they develop disease, they can see very severe acute diarrhea. It can be very voluminous, as you see in this picture. This horse here has painted the walls. We call this the Picasso in our isolation unit. So horses will develop fever. They'll be anorexic. They'll not want to eat. They'll have abdominal discomfort. The mucous membrane color will be abnormal. Instead of a nice normal pink color, they'll develop this redness, or we call injection, and they'll have a prolonged capillary refill time. When we press and blanch on their mucous membranes, it will have a very prolonged return to normal color. This all goes due to multiple factors causing these symptoms. So it's important disease in horses, but this is the important problem, is that there are a population of horses that can have salmonella and be shedding salmonella in their feces and be absolutely normal. This racehorse on the track have no outward symptoms, but have salmonella in their feces and can be a source of infection to other animals. So this was the reason that we wanted to study salmonella and to identify whether this population of animals is potentially a source of contamination or a source that we should be considering a source for salmonella. Salmonella is a very crafty pathogen. There are multiple steps along the way between infection and actual dissemination. And so it begins with adherence. Salmonella will adhere to the cell surface of a GI cell, the enterocyte. It will invade how do you get a bacteria into a non-phagocytic cell? So bacteria have ways of tricking cells to form vacuoles and internalize it, and then has to avoid evasion by the immune system and then multiply and then disseminate. And so those are basic research. Whenever we're designing our clinical studies, we go back and look at all the basic science questions, and we want to study those before we ask our clinical questions. So even though someone may be doing salmonella research in a lab in another part of the country, all the questions that they've already answered help us to design our clinical protocols in a way that are more efficient, more beneficial, and a better study. So regarding horses, their infection can be related to bacterial factors and then host factors. So some of the bacterial factors are related to the inoculum. So how much are they becoming exposed to? In a healthy animal, it requires higher number of bacteria, say 10 to the 6th, to cause infection and disease, versus a compromised animal, it's viewed as 10 bacteria potentially become cause infection and cause disease. There are many virulence factors within the bacteria itself, such as its own antimicrobial resistance, toxins that are produced, surface antigens that can affect how efficiently it attaches, how well it's internalized, and how virulent it is. Bacteria Salmonella can undergo spontaneous mutations or even have mutations that can affect its virulence that are transferred via plasmids through other bacteria, even normal flora, or other pathogens too. So Salmonella tends to share. Related to the animal itself, there's some host factors that are going to affect whether that horse or that is going to obtain Salmonella and develop disease. Age, we know based on some studies that those neonates that I showed you their immune system is not as developed. They're more susceptible to infection, especially that relatively small inoculum. Factors such as training and crowding, transportation, hospitalization are all stressors, and these physiologic stressors may affect mucosal immunity or may act in some way to promote infection in that particular cohort of animals. And then certain studies in horses have shown that particular factors that alter the normal GI flora could affect whether they become infected with Salmonella or not. So one important factor is antibiotic use. The horses that are on antibiotics that can alter the normal bacteria and microflora in their GI tract, and that could allow Salmonella to have a competitive advantage and to then invade. Things in horses, we tend to always stick with a fixed diet in horses. Any sudden diet changes alter that microflora and cause it to be disrupted, and that may also lead to the advantage of Salmonella invading. And then things like fasting, again, it's something where the animal, it will affect the bacterial population. So what percentage of horses are carrying Salmonella? Well, there are a number of studies in veterinary medicine that have examined that question, and there are very wide ranges that have been published. So looking at veterinary hospitals, some studies have examined horses on admission and performed fecal cultures, and it varies anywhere from 1 to 10% of horses were positive when they entered the hospital. They've also looked at just horses that are admitted for ICU. So those are going to be the sicker horses, maybe the animals that are more vulnerable to developing disease. And those around 5 to 6% have been published. And then looking at just gastrointestinal disease, since you might imagine that gastrointestinal pathogen may be more common in an animal with gastrointestinal disease. Again, there's quite a wide range, and it depends upon the number of samples that are collected and the individual facilities that are examined. So anywhere from 5 to 13%. So there is clearly many times a nosocomial of infection within a hospital. So prevalence among animals upon admission is always much lower than during hospitalization. So whether they acquire it or you can have community-acquired hospital-expressed disease, which can be very tricky to try to decipher when you're doing an epidemiology study. So why study racehorses? Though I've given you a lot of information about hospitalized patients. Well, one is there are a large collection of horses that are available for us to study, and they're potentially in large client-owned population. They're often stressed. So I said stress is potentially a risk factor. So they travel, they train, they race. So they may be more markedly stressed than just the average pleasure horse. And they are a referral source for veterinary teaching hospitals. So valuable information might be are they more susceptible to be carrying salmonella and be that asymptomatic shedder that I mentioned. So would we need to be more careful when we're admitting a racehorse? So sampling was done at, we have 4 racetracks in Louisiana, in case you don't know. There are Fairgrounds in New Orleans, Louisiana Downs in Shreveport, Delta Downs in Benton, and Evangeline Downs. It was formerly in Lafayette at the time of the study. It's been moved. Animals were randomly assigned. We tried to, many times the trainers would say, oh, I would like to participate in that salmonella study. I've got a horse that's always got diarrhea. So we certainly don't want to overrepresent any animals that potentially could have disease. So we wanted it to be as random as possible. So we asked the racetrack veterinarians and trainers to just randomly choose the horses. We asked them to flip a coin or to go every other stall or to have a random method. So fresh fecal samples were collected and serial samples were collected on Monday, Wednesday, and Friday. Horses are intermittent shedders of salmonella. So a single sample, you may actually underestimate your prevalence of salmonella shedding in these animals. If you, by increasing the number of samples, we hope to get a more accurate reflection of the true prevalence of salmonella among these horses. So we collected feces and inoculated into an enrichment broth. So salmonella being working with feces, you need to actually eliminate a lot of fecal bacteria that could interfere with your enrichment. So salmonella, we put it in a selenite broth, which helps to decrease the amount of E. coli and other gram-negative enterics that are not of interest. After a period of enrichment, we plated on a selected media, and then we look for characteristic colonies on the plate. So we look for these very dark H2S producing colonies. However, there's other organisms that can look very similar to salmonella, so we have to, beyond that, do additional biochemical identification using other triple sugar iron agar, lysine iron agar, and urease, and we look for a characteristic response. But to be even more sure, we use a commercial biochemical identification system on those bacteria that fit the criteria for salmonella. Ultimately, the API would tell us for sure if it was salmonella. We also wanted to use a PCR, since it's a very rapid method of identification, and it actually can help us to confirm and to help to augment our study. The PCR is more rapid than doing multiple stages of culture. Salmonella culture can take a long time. So by performing PCR, we could hopefully help to help validate it as a very useful technique. So feces, we found, of course, from other studies that enrichment was very important. So at least an initial period of enrichment. We took all 3 samples since we weren't concerned initially about whether they were positive on the first, second, or third. We just wanted to know Salmonella positive, yes or no. So we actually pulled all our samples. And I'll talk to you about numbers on why that was important. We performed DNA extraction. And anybody who's ever tried to extract from DNA from feces, there's a lot of inhibitors of PCR in feces. So you have to try to use special DNA extraction techniques to eliminate those. And then we perform PCR. So just to talk to you about numbers, we had decided on a sample size based on the population of horses that would be present at that particular moment at the track. So for instance, during the racing season, at peak racing season in New Orleans, there's about approximately 1,800 horses. So we calculated a sample size based on the prevalence and our expected variance, and we came up with 113 horses that were required. And we did start out with a higher number. We had some animal attrition, and I'll talk to you about that. But in the end, we ultimately tested from all 4 facilities a total of 429 horses. Remember, multiply that by 3, since there are 3 fecal samples. You can see it was a very smelly project. So, but in the end, the results that we found out was that the prevalence of Salmonella at the racetrack in New Orleans was about 4% at that particular time, 2% at Shreveport, 1%, 1.7% at Delta Downs, and then 0. We actually didn't find any positive horses at Evangeline Downs. So when we combined all our data together, we had an overall prevalence of about 2%. And so our conclusion was that we were suspecting that these racehorses are going to be a population that has a very high percentage of Salmonella shedding. And we found that actually Salmonella shedding among them is very low. However, it was detected at 3 of the 4 racetracks that we tested. So even under uncertain circumstances, they can develop an epizootic where you could have an outbreak of diarrhea and disease. But racehorses actually are under very intensive care. They don't mingle very much. And so they actually are a population that are really at low risk for carrying and shedding Salmonella. This percentage is pretty similar to some studies that were done in just a general horse population throughout the country. So we also examined some of our methods, and we found that a combination of methods was really helped improve our accuracy. We got multiple fecal samples, increased our likelihood of identifying positive animals. There were some animals that were negative on the first sample that were positive on the second or third sample. So it confirmed the fact that you should obtain multiple samples on these animals. However, the challenges of working with animals are you can certainly have to deal with the loss of subjects from the study, illnesses, injury, and animals could be transported elsewhere, moved to another farm for rehabilitation. Sometimes a client consent. We had a farm, a trainer that came in, and he says, I didn't consent to this, and so we had already started sampling from a large number of horses, and so we had to remove all of them from the study. So also, when dealing with animals, there are some variables that are more difficult to control than in an in vitro setting, in a laboratory. Animals in their environment, their individual physiology can affect that, and so I always say that this study always just talks about one point in time. Certainly, a lot happened in New Orleans after this study, so it would be interesting to know the effects of flooding in New Orleans had affected the Salmonella in that particular environment. We just don't know. And just one thing about working with animals is there's always has to be some concern about safety. So you're dealing with a 1,000-pound animal that can sometimes turn and look like that. Even when you're coming to get a fecal sample from them, they may not appreciate it. So, other challenges is that sometimes long hours, not only samples, but But in the end, so going back, so I started out the workbench inspired by a mentor many years ago that has kind of led me to clinical medicine and then back to the research bench. So I think, overall, these are, my patients are what's really worth it, and why I've always encouraged students just to never give up and follow. If it's your career path and you feel you're really called to it, you just continue on, and I think you'll be successful. So that's all I had. If there's any questions, I'd be happy to answer them.
Questions?
Yeah.
I remember you said something about how you image, the different ways you can image the horses,
Mm-hmm.
and you said CT scans. And I'm just curious because I know like patients, they get on the table and then they go through the gantry. But how would you get a big horse?
Yeah.
What does it look like? Is it a full room or is it still a table?
Yeah. Yeah. So
No,
we are limited as in horses. You're right. The gantry, we have a fairly large gantry, but with horses we can't put the entire animal in a large animal, a foal, smaller size foal. We potentially could, and dogs and cats are very easy to get them through. But regarding horses, we can often only image up to just beyond the carpus, or below the elbow on the limbs, and then from the head in the upper neck. So because of their size and limitations of gantry, we can't do full body CTs or MRIs. But certainly MRI and CT has helped tremendously in many of the diagnostics, especially musculoskeletal injuries to horses. We found things on MRI that were absent from radiographs, that and soft tissue problems that we didn't even know existed. So yeah, it is limited. You're right. Maybe someday we'll have a full size gantry. We could get a whole horse in, but not right now.
Thank you.
Mm-hmm.
Out of curiosity, who went on the vet school tour? Okay.
So you mentioned doing endoscopy
Mm-hmm.
on horses. So how well do they tolerate that?
Actually, there are some horses that we do when we're doing respiratory endoscopy. We often don't want to sedate them because sedation can affect the function of the larynx, and we might have an incorrect interpretation of their health. We may accidentally call it dysfunctional when it's really normal. So in respiratory, we sometimes use restraint in the patients, and we might use mild tranquilization, but we try not to do full. Now for gastroscopy, on the other hand, we do sedate them in tranquilization. So we go all the way to the stomach. Usually we don't, they don't tolerate it well without sedation.
Let me go ahead and ask the remote sites. Any questions, guys? Shreveport? Primate Center? New Orleans? Okay. They're a quiet bunch.
Well, help me thank our speaker one more time.